Well, good afternoon, everyone. Welcome to this special CFAR Center for AIDS Research at Johns Hopkins Symposium event for World AIDS Day. World AIDS Day, of course, is December 1, which is tomorrow, and that's why we're celebrating today. Always something of a somber day. It's hard to say sort of Happy World AIDS Day, but nevertheless, it's an important day to mark and honor, and we're delighted to be doing this session. Let me tell you a little bit about how the afternoon is going to go, because it hopefully will end with a positive celebratory note. We're going to present these talks on the implications of this special issue of the Lancet that we did, guest edited with several colleagues you'll hear about, for the AIDS conference this summer in Washington. This was a special issue entirely dedicated to the epidemics of HIV among men who have sex with men. That'll go until 3:30, and then we will go right into the announcements of the CFAR Developmental Awards. We're going to give away $650,000. Isn't that nice? Yes. And so I think what's going to happen probably is that around 3:30, we've invited a number of folks, and obviously all the awardees and all the applicants to come for that session. So don't be surprised if people start filing in at around 3:30. That'll take about half an hour, and then at 4, we'll have a reception with wine and beer outside. Since it's Friday, it's happy hour. All of you are invited to attend that, and the CFAR faculty and the awardees and applicants will all be there, drinking for different reasons, some folks, but nevertheless, we're really looking forward to that. This afternoon, this session will start with the talk by Dr. Stefan Baral. Steph is the Associate Director for Key Populations for our Center for Public Health and Human Rights, a faculty member in epidemiology. He's been doing a great deal of work with MSM, particularly in African contexts, but also in Mongolia and a number of other places. And he was one of the key co-authors on both the epidemiology paper for this series, which he's going to be presenting this afternoon, and the community paper for this series, which we'll give you a little bit of highlights from. And so without further ado, Dr. Baral.
Right. So is the slide check is it gonna show up? Let's see. Well, it's on my screen, but not yours. Is it gonna? There it is. Great. So thank you. So so it's great to have the students at Johns Hopkins here. We last did this in DC for a different crowd. So I'm presenting the paper today on the global epi of HIV among men who have sex with men, and I'll be doing that on behalf of a series of authors on the epi paper, including Fritz van Greensven, Steve Goodrow, Dr. Suat, Andrea Wirtz, and Ron Brookmeyer. So as an outline, I'll talk a little bit about the methods that we used for these analyses. I'll talk a little bit as well then about the burden of HIV among men who have sex with men. I'll look at the results of the reviews that we had from the risks for HIV infection, and we'll really look at both the biological and behavioral factors that came out of these reviews. I'll talk a little bit about molecular epidemiology because we really consider that to be important and part of the future of the understanding of HIV among MSM. And then I'll talk a little bit about the agent-based stochastic modeling of risk that was led by Steve Goodrow at the University of Washington, and finish with what we consider to be the significance of these findings. So the work really consisted of a series of systematic reviews, including reviews of HIV prevalence among MSM from 2007 to 2011, and that was really what was considered at that time the most recent data, so really looking at 5 years of data. Separately, we looked at the incidence or new infections among MSM. We looked a little bit about the risks of HIV infection, and then again, the pieces around molecular epidemiology. And then we finished with really trying to understand really the transmission issues among MSM and why these epidemics are so large among gay men and other men who have sex with men as compared to heterosexual populations. So starting with the burden of HIV among MSM. So what you're looking at here is a map of HIV prevalence pooled in different samples, again from 2007 to 2011. And what we really found was interesting was that there was a remarkable consistency of the burden of HIV among different populations of gay men and other MSM across regions. And so whether you look at North America, Central and South America, Sub-Saharan Africa, and South and Southeast Asia, you really see about 14 to about 17% of gay men and other MSM infected with HIV. It was higher in some settings like the Caribbean, although there was really limited data. And then it was lower in other settings like Western Central Europe, Australia, and Eastern Europe, with ranges from 3 to 7%. Here what you're looking at is us comparing the HIV prevalence among MSM to that of the general population. We do that because in many settings, gay men and other MSM have been accepted to be a vulnerable population for HIV. But in other parts of the world, they're still not considered to be an important population, either for epidemiology or for prevention programming. And so what we're looking at here is when you see the HIV prevalence among MSM in Sub-Saharan Africa, about 18%, compared to about 5% in the general population, with the recognition, again, that in Sub-Saharan Africa, these are mostly female-predominant epidemics. And so this is even sort of a conservative comparison. And this really holds true across regions, that irrespective of the geography of where you're looking, you see these concentrated epidemics among MSM, even in the context of fairly moderate and concentrated epidemics in the background. Again, the highest rates were really in the Caribbean. The highest rates were really in the Caribbean, but there was really a limited data set available. And I should say that even in 32 years into the epidemic, in that map that we were looking at, you still see about a third of countries that don't have any data among MSM, that have never done any studies. Most of those countries in Central Africa, parts of Western Africa, the Middle East, and even parts of Eastern Europe, former Soviet Union, really have very limited understanding of the burden of disease among MSM. So this is looking at now, we separately did systematic reviews looking at the incidence of HIV among MSM, so really trying to understand new infections. And what was really interesting from these is that in the context of a world AIDS pandemic that is really declining in orphans and vulnerable children, among young women, you really, when you look from 95 to 2011, see sustained incidence, so sustained new infections among MSM. And where it's not sustained, it's increasing. So when we looked at countries, many countries in high-income settings, including my own country of Canada, China, Thailand, other places, you're seeing these rising rates among MSM. So we haven't really seen any setting of the world where we're seeing declines in HIV rates among MSM, and that transcends high or low-income settings. So we wanted to try and understand what were the risks for HIV infection, and we looked at three main buckets of risks, including individual-level risks, network-level risks, and structural risks. So individual level risk is really what most epidemiological studies look at, and these are sort of our most proximal acquisition and transmission risk factors, looking at biology and behavior. And they're important, and we'll talk about it, but they really were insufficient to describe these massive epidemics among MSM in comparison to the risks that we see among heterosexual populations. Network level risks, there's an emerging understanding of these risks. So these are really looking at sexual networks. And so, among MSM, we're seeing larger sexual networks. We're seeing lower density sexual networks. And that's been shown to be associated with HIV in several settings, including China, Australia, as well as here in the US and UK. And then finally, structural risks. And so, there's really an evolving understanding of the role of stigma and discrimination in driving HIV prevalence as well as HIV incidence in some settings. So criminalization, stigma, both in the healthcare setting and outside of the healthcare setting, and really driving HIV risks among gay men and other men who have sex with men. So when we look at the biology, something that we hear a lot in the field is this issue that if only gay men, would wear condoms or have less partners, then there would be, lesser infections among these men. And so we really want to try and understand what was the biology here. And the biology is important. And what we see here is that from a paper by Bagley et al. A couple years ago, it's a 1.4% per act transmission probability with anal sex. And that actually transcends whether it's anal sex with men or penile anal sex with women. You see an 18 times higher rate than that of penile vaginal intercourse. So you're seeing this extremely high per act transmission probability. Separately, for per partner HIV transmission probability is extremely high. So when you either have a serodiscordant partner or unknown partner, per partner, you have a 40% chance of acquiring HIV. So imagine that if you just have 2 partners, you have an 80% chance of acquiring HIV with unknown status or HIV positive status. So the per partner transmission probability, again, is extremely high and mostly driven by receptive anal intercourse and less so by insertive. The separate piece outside of the per act and per partner transmission probability is really sexual role versatility. So as we all know, sexual roles between men and women are biologically determined, with men as insertive partners and females as receptive partners. But that's obviously not the case with gay men and other MSM. There's really flexibility in sexual positioning. So, and I'd love to be able to show you with the pointer, but when you're looking at the top row here, you're seeing an insertive gay man who's living with HIV. The man in the middle there, his acquisition risk for HIV really come from receptive intercourse with that man. But his transmission probabilities of infecting another man really come from then him being the insertive partner. And so you can see how the chains of transmission continue. And that's really in contrast to sex between men and women, where absolutely men as an insertive partner, the woman has a high acquisition risk, but her transmission risk to another man is actually quite low. So you can really see that spread within the sexual networks is actually much slower in heterosexual networks than it is among networks among MSM. Separately, we wanted to look at the molecular epi of HIV among MSM. And what we found, again, was really fascinating. We found that when you look at sexual networks and the spread of HIV, you see much faster spread. You see these bursts of transmission among MSM. And the way that plays out is that many more of these infections are linked than they are in heterosexual communities. As well, you see that MSM are much more likely to be infected with multiple variants of HIV. So again, their acquisition risk for different types of HIV and different strains of HIV is much higher than that in heterosexual populations, which generally just have one predominant strain of HIV. And then when we want to as well look at the strains of HIV that MSM are infected with around the world, because there's some really important things to see from this. So as we know, in US and Western Europe, it's mostly a B-clade predominant epidemic, as it has been for some time. But when we look at now the emerging data of molecular epi among MSM in Africa, what we can see is that it's actually quite consistent with what's happening in the general population. So in South Africa, we have a C-clade epidemic in the general population. That's also what's happening among MSM. Kenya has a mixed epidemic with A, C, and B types, and as well in Senegal you see a C and A and E recombinants, and that's also what's happening in the general population. So what the message is here is that in Africa, these epidemics are not split off, they're not protected from what's happening in the general population. In fact, they're perfectly representative of what's happening in the general population. In Asia, in the context, as I was talking about, of rising incidence rates, we really see this A and E recombinant that we used to only see in Thailand now emerging in other places. So in China, in Singapore, we're really seeing this A and E recombinant. And so we might be seeing sort of the emergence of a new and important recombinant of HIV that might be spreading faster and might be consistent with some of the increases in incidence that we're seeing. So then, as I talked about, we wanted to look at modeling the infectivity of HIV among MSM using this agent-based and stochastic simulation. And this is based on Susan Buckbinder's work for the PUMA modeling that she's done in San Francisco and Latin America. And it's based on a simple premise. It's us trying to understand whether if sex between men and women had the same transmission probabilities as that of sex between men, what would happen with the epidemics among MSM? And so, what we did was we modeled 5 years forward, so starting now, and looked at what would be the epidemics among MSM in 5 years' time with these assumptions. So the drivers, as we've talked about, among MSM, we know that we have a high per-act transmission rate for anal sex as compared to vaginal intercourse. We know that we have this unique ability for MSM to be both the insertive and the receptive partner during sex. And we know that for some MSM, a small proportion of them, there are higher numbers of casual partners. We use data from USA and Peru because that's really where the best cohort data is available on sexual behaviors, treatment uptake, and rates of condom use between main and casual partners. And as you saw, we started with an HIV prevalence of 15%, just based on where the data is and projected 5 years forward. And the results, I think, were really interesting. So when we just replaced the transmission probability of anal intercourse with that of vaginal intercourse in your first category here, you see between 80 to 90% decrease in infections over the next 5 years among MSM. So just replacing, again, the vaginal infectivity rates, that we know to be 18 times higher already makes most of the infections among MSM disappear. Now, when we use role segregation, and this is to say that 50% of the men would be perfectly insertive and 50% of the men would be perfectly receptive, again, mirroring about what's happening between men and women, you see about 20 to 50% declines in infections over the next 5 years. But when you put the two together, so this is really now mirroring heterosexual partnerships, right? So half of the people are insertive, half of the people are receptive, and you're replacing the transmission probability of anal intercourse without a vaginal intercourse, which is much lower. You see over 90% of the infections disappearing among MSM. And then in our last category, what we want to do is look at the role of behavior. So we looked at replacing the levels of condom usage in casual partnerships with that in regular partnerships, with the recognition that the condom use in regular partnerships we're not really going to be able to change. And so what we really want to do is increase condom use in casual partnerships. And what we see actually here is that even when we do that and we really increase condom use in casual partnerships, we see about a 20 to 30% decline in the infections over the following 5 years. So what are some of the key themes of that? Well, the key themes are that HIV epidemics in high-income settings, in low-income settings, in basically every country of the world, HIV rates are going up among MSM. And that's in the context of a World AIDS Day where many people are going to be celebrating the successes of declines in the general population, as they should be. And it's marked by high burdens among young men. So this is not something that's an age effect where people are growing out of this. These are young men acquiring HIV. There's rapid spread and clustering within networks, both social and sexual, of HIV among MSM. And there's this high frequency of dual multiple variants. And the drivers are really high per act and per partner transmission probabilities, the sexual role versatilities, and these network and structural level risks. And the modeling tells us that behavior is important, right? It's an important thing and we should focus on it, but it's not enough to change what's happening among MSM. And we need to start looking at the biology as well as the behavioral interventions. And really, again, this high transmission probability, this high force of infection, the potent effect of existing high prevalence among MSM means that we have to focus on reducing infectiousness as well as dealing with issues around condom usage. But the key message of all of this is that among MSM globally, HIV remains uncontrolled. And that's just a simple fact, that we are in a place right now where we need a reinvigorated effort. We need new approaches that really focus on biology as well as epidemiology. And we need comprehensive efforts by all of us, so by government, by academia, by community, and by HIV implementers that do the majority of HIV work around the world to reduce the structural risk factors that are really getting in the way of us being able to lower and address the needs of these men. So I wanted to thank a series of Hopkins students. The systematic reviews was an extreme amount of work over a year and a half. Marco Ambrosio, Sharina Kakayeva, Madeline Schleffer, and Darren Adams. I want to thank Susan Buckbinder because the basis of the model that we used came from them. And then we want to thank the CFAR, the Center for Public Health and Human Rights, and the Bill and Melinda Gates Foundation for supporting this work. Thank you.
So thanks very much, Steph. And our next speaker is Danielle German, who is, I don't know if I'm going to say your appointment. I'm going to let you say what your title is, because I know it's in flux. Faculty, yes. In the Department of Health, Behavior, and Society here at Hopkins, and who has been doing a tremendous amount of work with Be Sure and other projects with MSM in Baltimore. And we thought we should do our best to ground this World AIDS Day session where we all live and work. So Danielle, please.
We're going to take a technological pause for a second. Well, and then you start wondering, how do you organize this and how closely are they going to look? Okay. So it's completely my pleasure to talk about Baltimore and the city that we live in and the community that is rooted here. I have to say, when I sat down to think about this, I was like, oh, sure, you know, it's great to be able to talk about this. And then I sat down and I thought, when we talk about this, we've sort of done this talk a number of times, and we've talked about the fact that there is an MSM HIV emergency here in the city a number of times, and I'll share with you some of the information that sort of informs that. But then it sort of felt like, well, what more can we talk about? So I'll share with you sort of what is informing. I think what you're probably hearing is the tone in my voice, and hopefully some of what we've been thinking about and sort of trying to move forward in thinking about this. So about 4 years ago, I had the privilege, really, of taking over a project from Frank Sabakis, who was in the Department of Epidemiology, called the Beyrer Project. And it's part of CDC's National HIV Behavioral Surveillance Study, which is operating in about 20 cities around the country with the highest HIV prevalence. And as part of that, our task is to monitor HIV prevalence and related behaviors and testing behaviors and that sort of thing among the communities at highest risk for HIV. So those include injection drug users, high-risk heterosexuals, and notably here in Baltimore, men who have sex with men. And what that means is that every 3 years since 2004, our team of really, really wonderful research members have done venue-based data collection here in Baltimore. And what that means is exactly what you see up here on this screen, which is that we have these very cute vans and we have these very wonderful dedicated staff members who are willing and able to go out into the community at any hour that's appropriate, in any weather condition that's appropriate, to really be able to work with our local community to be able to find out information that becomes really valuable for HIV prevention. And we do this in direct partnership with the state health department so that our information goes directly into their hands for prevention planning. So what we do is a behavioral survey that includes a lot of different topics. Everything is anonymous. And then we also do serological testing for HIV, as well as a few other biological tests at different points in time. And so we did this in 2004 for the first time. And what we found was that it in a lot of ways, except for the men who were experiencing this themselves, who knew what was happening in their community, what we found documented a very, very high rate of HIV among MSM in Baltimore. And so what we saw was about 30% HIV prevalence. And within that, when you look at the difference between white men and African-American men, we saw very, very severe racial disparities where 13% of the white men that we saw were HIV positive, and almost exactly half of the black men that we saw were HIV positive. And then also, pretty critically, we found that of the people who tested HIV positive with us in the study, the vast majority of them, particularly among the African-American men who had a very high rate of HIV, the majority of them did not know that they were HIV positive prior to testing with us. So that was 2004. And in 2004, 2005, there was a lot of sort of local dialogue about this, and it really caught a lot of people off guard. Then we went out in 2008, and to be honest with you, what we were really hoping was that we did it wrong the first time around. It's something we were, and I think there was a lot of sort of local partners who really honestly thought that we did this wrong. And what we found is pretty much the exact same HIV prevalence. And I want to say we use the exact same methods over time. It's not this. It's not a continuing cohort, so it's new people who are participating, but we use the same methods. So we saw the same HIV prevalence. We saw a very, very similar racial disparity. And we actually saw that this time around, the proportion of people who knew that they were HIV positive was actually higher than the last time around, and that it was more distributed. So also among the white men, we were seeing a lot of people who were testing positive. Those numbers are small, but even so. So that was 2008. And so in 2008, when we had this sense that it was, that we didn't do it wrong in the first time around, that made everybody really start to feel scared. And so the word emergency and the word crisis started really being very much a part of our conversation. So that was 4 years ago. And we then, 3 years go by, and so we went out last year to do the exact same sampling method. Again, hoping, we now believed what we were seeing, but hoping to see some sort of sense of progress. And so these are our results from the data collection that we completed this past December. And what we saw was HIV prevalence was 42%. And I want to say this is primarily because we had more African Americans participating, not because of a natural sort of increase in HIV prevalence. Again, we saw about half of the Black men, 16% HIV prevalence among white men, and our unrecognized infection number sort of fits right in between what we've seen before. So essentially, we're seeing a flat line in both. So we've essentially had what we consider to be an emergency happening for a long time. Now, what is also sort of interesting is just how this fits into the local conversations about HIV and what's going on with our local epidemic. And so what this shows you is just trends in proportion of diagnosis attributed to different risk categories in Maryland. If I were to show you this specifically for Baltimore, sort of the Baltimore region, it looks very, very similar. And so this starts in 2000. So you can see in the year 2000, about 20% of the overall new cases were attributable to MSM. And then if you sort of look over 2004, when we did our first survey, again, about 20% of the new cases were among MSM. So bottom line is that this was not on the prevention radar. But since that time, if you just follow that blue line up, so then we see 2008 when we did our second round, where we're up to about 38% of new cases are among MSM. And 2010, the most recent data for this slide, is that we're at about 45% of new cases are among MSM. Newly diagnosed cases are among MSM. So the other surveillance systems are really starting to mirror what we saw early on in our venue-based data collection. What this means is that the local conversations about what's going on in MSM and what do we need to do about MSM have changed pretty dramatically. And there are a lot more people on board, and there's a lot more buy-in about about what's going on. But then the question becomes, well, what is really going on? And so this is, to my knowledge, the one and only time that the Baltimore Sun has covered the HIV epidemic among MSM in Baltimore. And this is 2010, and this is when CDC released an MMWR showing that not only did we have the rates that I just shared with you, but among the 20 participating cities, so the cities with the highest HIV in the country, that Baltimore's rates among gay men were the highest among all of those cities. But notably, they mention that, but they don't say anything about the racial disparities. So we, like many other people, have spent some time trying to figure out, well, what's different between African-American MSM and white MSM, and how can that help inform what we do. And what we've seen, this is from our last round of data, so what we've seen is that to some extent, Black men are the Black men that we see in our venue-based recruitment, so I want to be clear about that, are somewhat younger than white men, a much lower level of higher education, so about half of them are, twice as many of the white men have gotten more than a grade 12 education. We don't see, and this is similar to what others have seen, we don't see a lot of differences in sexual risk behavior. We see a little bit where Black men are seem to have a slightly higher proportion reporting unprotected anal sex with casual partners, but not so much in terms of number of partners. A little bit of more likely to have both male and female partners. But where we see pretty severe differences are when we look at social characteristics. And so the African-American men are much more likely to be unemployed, much more likely to have been to have been homeless in the past year, seemingly more likely to have ever experienced homelessness, much more likely to have been ever incarcerated. So about half of the Black MSM have been incarcerated at least once in their life, and a high proportion reporting recent incarceration. And then a little bit higher proportion of non-injection drug use, particularly cocaine, crack, and heroin. And then looking at healthcare and service utilization, and particularly testing patterns, there does not seem to be very much difference at all, except that Black men seem to have actually been more likely to have gotten any STD test in the past year. So then when you talk with, when you sit in a room and actually talk to the people whose lives we're actually talking about here, and you ask them what's going on, what comes up really, really quickly is the experience simultaneously of the likelihood of experiencing racism, experiencing homophobia, and also high levels of HIV stigma. And so this is a sort of brief attempt to capture some of that, where we just asked, in the past year, had you experienced any form of stigma or discrimination just in the past year because of your race, ethnicity? So about 30% had experienced some form of racism in the past year. 35% experienced some form of stigma due to somebody perceiving that they might be gay. And about 20% reported some form of HIV-related stigma, and this was much higher among the people who previously knew that they were HIV positive. And notably, oftentimes people were not just experiencing one of them, but were reporting experiences of across those categories. So I kind of want to end it there with, so I had a conversation this morning with one of our community partners that works really closely with us, and I asked him what I should say today. And the first part of our conversation was that talking about this as an emergency doesn't really seem to be, it's, could be appropriate, but doesn't seem to sort of engender the feeling. But what he said specifically is what we need to start saying is that for the people we're talking about, HIV is not a priority and really not the worst consequence that's in their mind at any particular time. There's so many things going on in their lives, and the immediate things that are going on are things that we really need to be talking about. And this really rang a bell with, actually, this is a quote from a nice piece that was published on the Huffington Post very recently. And it just talks about the idea that when we talk about Black men, gay men of color, Black MSM, that we need to also remember that we're not only thinking about them because of HIV. And so what he says is, instead of throwing a condom in a young gay black man's hand, first consider what his world looks like, what are his life circumstances, what are the societal barriers that are preventing him from getting the message on HIV. Is it poverty? Is it homelessness? Is it unemployment? Is it racism? How does he identify? How does he view himself? Does he feel like he has any worth? And this is important, because if he doesn't feel like he has any worth, then how can he value his physical self? So I'll leave it there. I think that's a helpful place to go. So just all of the work that we've done on this Beyrer study is due to a lot of tireless efforts from a lot of people over time. So this sort of starts to touch on that group of people, and I'll leave you with their images. But thanks very much. And I'm just going to log out of my Dropbox before I.
Oh, yes, please do. Well, thanks so much, Danielle. And I having heard that emergency for a long time, I think you're right. I think we need to reframe that and rename it. It doesn't mean it's not an emergency, though. Our next speaker is Carl Latkin, who's a professor in health policy and management and one of the leaders of our CFAR Prevention Corps. And he is going to talk about what do we do with this epidemiologic data, both globally and from Baltimore. So, Carl, please.
Thanks, Chris. It's funny because Chris asked me to do this knowing that I had been involved in the Lancet series. I was involved in the Lancet series on IDUs, so I just did a search and replace IDU and put it in MSM. So there was some really nice articles in the series on prevention. And so what I thought I would do is try to link what was in the articles to the Baltimore scene. And really what these, one of the articles did was go through systematically and look at different approaches for prevention and really see where we're going to get our bang for our buck. And so these are the main foci of the article and what I would focus on in my talk. And what was nice about this article was that it wasn't just saying how effective these types of interventions are, behavioral or biomedical. It was really talking about where is the interactions and the intersections between the behavioral and the biomedical, and as importantly, what are the structural factors that really impede our implementing some of these interventions. So clearly, condom use and antiretrovirals are two clear interventions that we know could have a significant impact on the epidemic. We also know that screening and treatment for STIs is important, and also promoting disclosure. So these are some of the key factors we know are effective in reducing transmission. But I think when we think about Baltimore, we really have to think about what are the other key aspects of our population, especially African-American men who have sex with men. And certainly Danielle touched on these first issues, that if you look in all these slides, the vast majority of our populations are unemployed, and they experience a lot of violence. How can we make HIV priority when you have these other issues going on? There's also a fair amount of substance use, but there's really, as far as I know, most of the treatment centers are not friendly to MSM or are not really focused on that population. As well as there are certainly clinics that have MSM population, but less so, or African Americans feel that those clinics are not serving their needs as well as the white population. And as Steph talked about, the youth, often we're seeing people who are already infected in their 20s. So we really need to develop programs that get kids in school, that get kids, as you know, a lot of Baltimore high school students have already dropped out. So we can't just look at the schools, we also need to focus on kids who are out of school. Another thing is often when we're thinking about biomedical interventions, when we're thinking about risk reduction, we're really thinking about individuals. We're not thinking about public health. We're thinking about reducing individual risk. But how do we think about harm reduction in really a public health perspective? And these are some of the questions that I came up with. For example, for HIV positives, do we encourage them to serosort? Do we say that's a harm reduction method that we endorse? Or are we thinking that that's not a good public health message? But we really, as public health practitioners, haven't really come to grips about what is going to be our harm reduction message. Also, even treatment. We always think about treatment as good for the patient. Getting patients on treatment early is good for a patient, but it's also good for the population. If we can reduce viral load in individuals, then obviously they have less chance of transmission. And as well as we have lots of these know your status campaigns, but it's all focused on individuals, that they can know their status so they can do something healthy. But what about the community? How does knowing your status help the community? And it's interesting, at least in talking to African-American men, there is some knowledge about pre-exposure prophylaxis. There is some knowledge that this may be an approach to curbing the epidemic. But what you find is really surprising is there's very little talk, very little knowledge of post-exposure prophylaxis. And when you think about it, that's a known and effective method of treatment for prevention. But where in the U.S., or excuse me, where in Baltimore would you go for post-exposure prophylaxis? I know where you'd go in San Francisco or New York, but I really don't know where you'd go in here in Baltimore. More clinic. So what I did was I went on line and looked at the health department and looked what I could see there, and I couldn't see anything. But I don't think there's that much knowledge in the community, at least when I talk to men, of where they'd go. But also we think about structurally, do we have structures? So if 100 people came in the door, Joel, could you handle them?
Well, no, but that's unlikely.
Right, I know, but it just seems like all the focus is on PrEP when we know PEP works, but we really haven't even disseminated that. And then thinking about PrEP, I think it would really take some, hard discussions about figuring out who do we think as individuals and as a community would be most appropriate for it. And in one of the other CFAR talks earlier in the quarter, and Joel, you were involved in that, people were asking, okay, when is PrEP indicated? And we really don't have a good set of guidelines thinking about the epidemic of where we'd actually, where we think it should be implemented, for how long, under what conditions, and is it really going to have a population effect? There's some great modeling of this in the Lancet paper, but we're still, I think, thinking about it on an individual level. Now, there was also in this Lancet series an awesome paper, I thought, on leadership and men in the community who have sex with men, the role of leadership in prevention. And I thought it had some really interesting aspects of it. And the first one was that really the diversity of the community. And you see that so much in Baltimore. If you bring in a random group or just a group of African-American men who have sex with men, who are individuals I work with, you see this huge diversity. You see upper status, low status, young men, old men, people who usually in their interactions don't interact. So I think it's very important that this Lancet article has identified that the community is really fragmented in many places. People's identities may not be about having sex with other men. And so what we need to do is figure out how those individuals are linked. How are their social networks linked? What things do they share in common? And how do you use those links, those social networks, and those shared values, cultures, and political affinities to promote prevention? So one question is, based on the importance of community, what do we want to change? We say we want to do community-based interventions. What do we want to do? Obviously, we want to reduce incidence of HIV, but I think some of the key things we want to do on the community level are the norms of risk behavior, that it's make it less acceptable to engage in unprotected sex. Norms of increasing testing, disclosure, and also change on a social level the meaning of condoms. Clearly in the community, there's still stigma, especially the African-American men who I interact with. There still seems to be a lot of stigma around same-sex behavior. And one question is really, how do we address that? That's something that clearly needs to be addressed on a community level. And can we use some of the political momentum of recent like Marriage Equality Act? Could we organize a group like that to promote stigma reduction? And as you saw from Danielle's slide, we're doing a very poor job on testing. If that many people don't know their status, we clearly have to have a much more greater community mobilization effort to disperse or to recruit people for testing. And home testing kits are one approach. Community outreach is another. And I thought this was a very nice quote also from the Lancet article, and really emphasizing that it's not an option to get the community of MSM involved. If we really want to adequately address the epidemic, if we really want to change behavior and change seroincidence rates, community involvement is really key. That it's not something we can just add on to our studies. So one question is really, how do we foster community change? How do we get the community involved? And I think one thing we've often talked about is behavioral interventions versus biomedical interventions, or a combination of behavioral and biologic. But we know a lot about behavior change, but we don't really apply it that well to fostering community engagement or fostering leadership. So we know a lot about behavior change, but we're not training leaders in the community, or there's not a lot of evidence of that of the MSM community. So how do we, what skills do those leaders need? How should we train them? How do we foster networks of MSM and promote shared goals and shared cultures? And although we do this internationally and we talk about the workforce that's needed to reduce HIV, we really don't talk about in Baltimore. What workforce do we need? And is that a paid workforce? Is that a volunteer workforce? Who should really be involved in this struggle? So I think we're really good at behavioral interventions for individuals, but we really need to take our expertise and promote it to diffusing behavior change through the community by training leaders, by forming networks that lead to communications and norms changes, and really utilizing our medical and behavioral knowledge to really make the Baltimore effort a community level effort, one that's really led by men who have sex with men in Baltimore. Thank you.
Geez, that was a great talk. All three, really, very, very sobering. There's always a danger in being the last speaker, which is, of course, that people are going to say a lot of the things you intended to say, and they're going to say them better. So where is this one? But let me just go through a couple of kind of final thoughts for you, and something of a framing of the global response, taking us back out of Baltimore globally to think about this also in terms of a human rights struggle. Because while in this city and in this state, thank you, voters who voted for marriage equality, we have just had a win for human rights and social justice in Maryland. It's an applause. Yeah, yes. Woo-hoo! In much of the world, of course, we are seeing either no movement in social equality and social justice for sexual minorities, or going backwards, unfortunately. And that certainly frames the lives and the risks and the HIV experience of men in so many places. Now, Carl just ended with a call for community involvement, community engagement. I think on World AIDS Day, we have to look back and remember that, of course, the first real responses to this epidemic indeed were created and led by gay men. These are some ACT UP images from early on. Healthcare for all, an early call that in many ways has started to begun to be realized with the Affordable Care Act. but also, of course, many sacrifices. The person up in the corner there is David Kato, Ugandan leader and social justice activist for gay men, who was murdered. And of course, as many people in the audience know, Uganda is now actively moving forward, it seems, again, with this anti-gay bill that will include the death penalty. It's gotten out of committee. And so we're very worried about that. And of course, what people face and fear in those settings is things like this. This is a Rolling Stone magazine. It's a Ugandan newspaper that has been publishing the names, photos, and home addresses of gay men. And of course, inciting just the opposite kind of community responses that we want to see. I think as public health people, and for those of you who are future investigators, there also obviously is an important element of still uncovering these epidemics. As much as you've seen this tremendous data from Baltimore, from the US, and data that Steph showed you from the rest of the world, this also is from that last paper in the Lancet series, The Call to Action. And in white there, and you can see that it's a lot of the Middle East, North Africa, and the African continent, are the places where still 30 years on in this epidemic, there has not been a single data point on prevalence for MSM. So that is an undone task, and I invite all of you to get engaged. You've got to fill in the rest of that map. All right. And we need to end invisibility, obviously not just in epidemiology, but in service delivery and in decision making. It really is an extraordinary thing to be a part of right now. Steph is doing a lot of this work, and many of us are involved internationally, that LGBT communities are emerging all over the world, and they're emerging in Africa, and Eastern Europe, Central Asia, and South and Southeast Asia, and demanding inclusion, facing very, very tough challenges. But rather strikingly, they're emerging in the context of the HIV pandemic. Sort of the opposite situation from what happened here, which is that we had a vigorous LGBT movement, the first one really in the modern world, and then the HIV epidemic came within a decade of that movement. For these folks, they are starting to, come out, get together, organize as communities, and already facing enormous burdens of disease. So there's a basic package that we're calling for. This again is from this call to action. Obviously, expansion and testing, critical everywhere and critical here. Treatment, both for the individuals who need it, but also for the tremendous prevention benefit. Condoms and lube, and I'm just going to talk a little bit about some costing that David Dowdy did for us in this paper. And it's really striking, again, 30 years on, how many places men don't have access, for example, to condoms and appropriate condom, water-based or silica-based lube. The mental health issues were addressed in the clinical paper, which for those of you who are interested was led by Ken Mayer. The substance use issues were also there, and indeed also the provider training, which is really a critical part of these services. We also laid out for this research priority. You've already heard about the unmet epidemiology needs. There are important economic questions, and particularly around the economics of interventions like PrEP, which are so expensive in the US. There's still a basic science research agenda here. The bad news, as you saw from many of these, is that it isn't entirely clear that we have, for this population, adequate prevention toolkit at present, and probably the two most important basic interventions still to come are a rectal microbicide, where there's some enthusiasm there. There's actually a phase 2 getting going of a tenofovir gel reformulated for rectal use, and of course the HIV vaccine, which we hope is going to be evaluated in populations with this risk for exposure. Vaginal transmission or penile vaginal transmission and anorectal acquisition of HIV are not the same immunologically, biologically, and we really need to do vaccine trials in populations with different risk exposures. Happily, another human rights victory. Are you ready for your applause line? The end of Don't Ask, Don't Tell, yeah, has has created an environment where the military HIV research program, assuming we don't go off the fiscal cliff and it survives, is proposing its next trial actually in Thai MSM. And that, of course, is because we now are in a policy environment where we recognize what has been true for decades, which is that most of the infections in the U.S. military are in fact among MSM, in active duty military, and so a vaccine really is something that relates to preparedness for the U.S. military. We need to do trials of these promising approaches, and so we really need to continue the clinical trials infrastructure. And then, of course, these structural changes and social and cultural factors that all three of the speakers have spoken to really matter. And I would just highlight one little bit of data. As an epidemiologist, I cannot resist, one busy, dense table that's unreadable. But nevertheless, what you're looking at here is an analysis of associations of fear and discrimination with sexual health in the use of health services. So this is enacted stigma and discrimination in healthcare, a project we did with MSM in Malawi, Botswana, and Namibia. And just to say that what you can see here, if you could read it, the last column is all I'll really address, which is when we did the qualitative and developmental work for this, men kept bringing up blackmail, that discussing or openly disclosing their sexual orientation, gender identity, led to risk of blackmail from health providers, right, from service providers. And it's an enormous barrier to people to being open and disclosing who they are. So men who knew they were HIV positive, 5 times as likely to report blackmail risk. Men who'd been self-reported diagnosis of HIV, people who'd been recommended for an HIV test, and men who had any interaction with healthcare, more likely to have been blackmailed. Well, that, of course, is a structural barrier and a social barrier to accessing care. One of the other papers in the series, and I thought I would just briefly speak to it, is a brilliant piece of work led by Gregorio Millet, who is at the White House and the CDC, looking at this issue of health disparities between black and white men and using the very familiar now treatment cascade to look at this. So you start up in that corner. This is comparing black and white men in a systematic review, a meta-analysis for all the available data for the U.S. And black men basically about 6 times as likely to have undiagnosed HIV infection, about 2.5 times as likely to be diagnosed, about half as likely to have health insurance, about half as likely to have ART utilization and uptake, little less than half, about 40% as likely to be treated above 200 CD4s if they do get treated, somewhat lower adherence, and of course all of that adding up to much lower likelihood of being virally suppressed. And that measure, the proportion of HIV positive people in a population who are virally suppressed, is emerging, of course, as a critical, not just assessment of healthcare, but also as a critical component of ongoing transmission, right, of risk of transmission in networks and populations. So I think this cascade is really enormously helpful. The second part of what Greg did was then pull together the social and structural elements of this. So you can see the health insurance coverage, lower income, about 3 times as likely to be low income, and to have many fewer healthcare visits. Now the good news here, this is the last applause line, is everybody ready? Is the Affordable Health Care Act, yay, has survived and is going to extend healthcare to 37 million Americans, and hopefully is going to begin to address precisely some of the healthcare problems in this critical cascade. I just want to say that some of these structural issues are also going to be about cost disparities. So Carl talked about PrEP and the importance of PrEP. Truvada, as an example, the estimate is roughly about $12,000 a year per person to put somebody on oral PrEP in the U.S. The great majority of that, not all, but much of it is drug costs. It's 43 cents a day in Thailand for a Truvada pill, right? So it is actually a quite affordable intervention in a number of other countries. And again, this is work by David Dowdy. What you're looking at here is the combination of costing out as a proportion of global cost and as a proportion of HIV infections averted, low, middle, and high income interventions. And the bottom line here is basically that a huge proportion of, for example, PrEP costs are in the first world, mostly driven by drug costs. But a huge proportion of the benefit of PrEP would be among developing country MSM. And so the future here is really going to require also, we could even have a boo hiss line here, marked reductions in the cost of pre-exposure prophylaxis, right, in the first world. We also costed out just the basic minimum of condoms and lube, looking at what it would take to reduce HIV infections globally over the next 10 years. And that is the relatively modest investment of $134 million. Cheap, is it not? Relatively cheap. So, you know, you'd have to ascribe at least some institutional homophobia to the fact that we have not done that. So let me just frame this a little bit as a human rights issue. First of all, very encouragingly, there's been an independent commission on HIV and the law that has reviewed laws globally, both laws that improve the HIV response and laws that impede it. They have come out very strongly with the fact that laws that criminalize same-sex behavior between consenting adults undermine effective HIV programming. And for those of you who are interested, I think that commission's report is out and it's online, and it's really a great read. When we looked at this for the Lancet series, we ended up using the Yogyakarta principles, which probably are the most articulated set of human rights principles relating to sexual minorities. And I'll just highlight here a couple of those human rights principles that really seem the most relevant. First of all, of course, virtually all the international human rights documents talk about the universal enjoyment of human rights. And universal does not mean universal except everybody who's homosexual, right? Universal is universal, which we love. The right to the highest attainable standard of health applies to everybody, and again would imply that prevention services, and nobody should be excluded from prevention, treatment, and care because of sexual orientation or gender identity. Protection from medical abuses like blackmail is a fundamental in health rights. And finally, the right to found a family is widely established in international human rights law, and everybody has a right to found a family. Of course, this has been formulated in the Obama administration, most clearly by Secretary Clinton. This is a reversal. Some years ago in the Bush administration, poor Condi Rice was tasked with the job of standing up and saying the United States stands with Iran in opposing equal rights for LGBT people, a low point in American foreign policy. But we now have Secretary Clinton, at least for another few weeks. And she, of course, famously said at the Beijing Women's Conference, women's rights are human rights, right? And human rights are women's rights. And she reformulated this at the UN Human Rights Commission. Gay rights are human rights, and human rights are gay rights. Isn't she fabulous? And I'm going to just close by saying that when we think about interventions to address the social aspects of stigma and discrimination, really where Carl was leaving us off, it's incredibly important to bring voices from outside of public health and medicine, right? Because we are not, I hate to tell you, particularly the students in the room, the most influential people in every society, you know. Despite the fact that we think we should be, there are many, many other voices out there, political voices. And there, of course, are voices of faith who have enormous sway in dealing particularly with the social discrimination, stigma issues around homosexuality and same-sex behavior. So we have a champion among African Christian leaders and among world leaders in Archbishop Desmond Tutu, and we asked him to contribute a piece for this call to action precisely because we wanted to get his voice weighing in on equality. And I have to tell you that when this series went live, it was during the International AIDS Conference, we were all excited about our stochastic agent-based modeling and about our fabulous epidemiologic slides. None of that was picked up by the media. The only thing that really got picked up in the international media was Bishop Tutu. And particularly by the international gay media. It was kind of everywhere. So you could read this for yourselves, but let me just read it to you aloud, and then we'll open up this to the panel discussion. For the LGBT youth out there who are struggling, who are made to feel inferior, let me say this. God loves you as you are. He wants you to live and to thrive. So please take care of yourself, educate yourself about HIV, protect your partners, honor and cherish them, and never let anyone make you feel inferior for being who you are. When you live the life you were meant to live in freedom and dignity, you put a smile on God's face. Thanks very much. So can I invite the panelists to come on up, and we have about 20 minutes or so for questions and discussion. While folks are taking their seat, I just want to thank all of the contributors to this work. Again, the funders, which was AMFAR and the Gates Foundation and the CFAR. And let me just say that when you get asked to do one of these series, which is a lot of work, but also can be a really impactful thing. You have to raise your own money, so we really appreciate the donors for doing this. And you get to bring in other guest editors, and our guest editors for this series, in addition to myself, were Ken Mayer from Harvard, Patrick Sullivan from Brown, and Jorge Sanchez from Impacta in Peru. And so you're seeing a lot of their work and support here as well. So, although the mic is over there, so I will join the team and sit down, and then please, love to have your thoughts, comments, questions.
This is a Baltimore question. Is it on? No? Okay. This is a Baltimore question.
You know, I work on HIV in Baltimore, but I work on data, so it's like living in a cave. So I was really struck by these ads for status update, and I was wondering if anybody knew anything about that project. The status that was done through the health department. It came up. Let me see if I can find these things here. It was have balls get tested.
Oh yeah, so what was striking about it? So it's an HIV testing campaign that's designed to be targeting African-American MSM. And it's not Baltimore specific, but it's implemented in Baltimore as well as a variety of other cities. CDC is a huge player in that.
Yeah, because the ads were very, I thought they were very striking because they had a lot of different, were they done by the Baltimore, you know, they were done for the, visually striking in terms of the people that they used. They were done with the School of Art, College of Art, and they used Baltimore men, different levels of, you know, black men, you know, very, I guess you would say some butch men, some, you know, different levels, you know, you could see the whole spectrum of you know, the LGBT, I mean, the gay men of color. You could see the whole spectrum of that, and I had thought that looked so amazing in terms of ads, and I just thought that looked like, if anything, something that would catch the risk group and have them get tested, and so that's not really a big thing. Okay.
No, it's a nice. It's. I mean, you're right. They're visually compelling in a way that a lot of the social marketing campaigns have not been. And they did do some nice partnering with local, particularly the ballroom community, in putting together some of those ads. What's interesting about those ads is it tends to spark conversation among the people that it's not targeted for.
Okay, yeah.
which I think is very important as well. So yeah, they're an interesting addition to the landscape for sure.
Please.
I just wanted to know if there were collaborations happening with other research institutions in Baltimore.
Yes, to some extent. So there certainly are some University of Maryland and Hopkins collaborations, and I think that you know there are probably more informal examples of people. I don't even want to say across institution, sort of regardless of institution, coming together who care about this and sort of trying to bring heads together. But I think there's a lot more that can be done in that. We have a lot of we have a lot of resources in that way locally, and I think there's a lot that can be done to sort of mobilize that and connect it to those outside of the research institutions, which, you know, the capacity and sort of bridging to community, I think, is a huge direction to go to.
And one of the parts of the CFAR is the Baltimore theme. So the CFAR is acutely aware of the issues in Baltimore, and you know, there's a group from the CFAR struggling with how as a large entity such as Hopkins do we interact in a way that's more effective and has a greater impact on the community.
Please.
I'll take a risk on this one. Is one of the things that I rarely, if ever, hear discussed is, and as a gay man for many, many years, is it seems like there's a human nature, a draw to want to exchange bodily fluids. Like there's this natural instinct to do that. And I think what's not talked about, that's not talked about. And I think there's so much conversation about preventing, you know, condoms, limiting all of that. But I think part of the dialogue might need to be just perhaps to acknowledge that. At least that's what I hear and that's what I experience. And so much of the conversation is not allowing that to happen. Does that make sense?
So I'll take on a partial answer to that question, because I think, you know, it's an important insight, right? And one of the things that it's about is the relationship between condom use and intimacy, however you want to, you know, phrase it, and what people mean by that and how they experience it. And I think across populations and across orientations and genders, there's a consistency that condom use falls off as intimacy increases, and it's, you know, very human. I don't know that it's gay or straight. I think it's, you know, I think the evidence suggests that is very consistent. It's easier to promote condom use, for example, in many heterosexual cohorts, and there's tremendous data on this, with extramarital partners, with casual partners, with commercial partners. There's very good data from the sex work literature for years that when sex workers control you know, the dynamics of sex work, that condom use is very high. But then with their intimate and primary partners, condom use rates are low. So I think it's human, right? And the challenge there for us is that a substantial proportion of transmission is within primary partnerships. And beating people up over not using condoms when it clearly goes in the face of that function of intimacy has just not worked. Now, with gay men, the estimates vary that, you know, perhaps it's somewhere between 1/3 and 2/3 of infections occur within the context of primary partnerships, and somewhere between 1/3 and 2/3 outside of those primary partnerships. So it's an important component. It might be a majority component, but whatever reality is, we need preventive interventions for both of those contexts, and probably condoms are not going to be it for stable partnerships. And so that is, for example, where the role of treatment is prevention, where, you know, testing and having couples-based testing, which is emerging as a critical new area for MSM for gay men, is going to potentially make a difference. Where, you know, interventions like effective treatment that reduce infectiousness are going to be important, where interventions that reduce acquisition probability in the absence of condoms, like PrEP, like a rectal microbicide, like a vaccine, also have some real potential. But there's no question, I think, that this is a horse that has been beaten to death for 3 decades. We're not expecting to make much headway in the area of higher rates of condom use that will high enough to make a difference in transmission at population levels in intimate, stable partnerships.
Can I just sort of add a spin onto that? So, I mean, I think behavior change in almost any disease entity has been limited success, right? So, you know, hypertension, diabetes, whatever, getting people to wear seatbelts. I mean, you know, so I think behavior change has its role. You know, as a family doctor, you tell people to exercise. and you tell people to eat healthy, but we recognize with issues around obesity and hypertension and growing epidemics of diabetes in this country and in many countries of the world, it's not working. And so I always think it's interesting as sort of a younger investigator here that like the focus has always been on behavior change in sex, which is like the most intimate of things, when we can't even get people to like go to the gym or walk around the block a few times a day. And so, I mean, I think that again, that behavior change has a role, that it's always been an important phenomenon, but that addressing biological issues like we do in diabetes or hypertension or any of these other disease entities is going to be just as important, or likely more important, if we actually want to change things.
Well, a counterpoint to that is how many people here smoke? So what's happened? It's an individual behavior. It's people change their behavior. Cessation rates have been high in upper class populations, but there's things like secondhand smoke laws that have changed social norms about the acceptability of smoking. So I don't think it's an either or of behavior or biomedical, but I think we have to look at what the leverage is and where is the behavior change. Is it at an individual level? Is it diffused to a network, or we really want to get a community level behavior change?
Joel?
Yeah, just following on the last comment, one of the common arguments against PrEP is that someone who won't use condoms can never be expected to take a pill. And of course, that assumes that the reason you don't use condoms is because you're non-adherent, rather than that it's a deliberate decision that's not the way you want to have sex. So the idea that there are many people who would be happily take a pill, but who would not wear condoms to prevent HIV. And so as long as we look at failure to use condoms as an adherence problem, we're not going to get the point that we need to have other ways to prevent HIV for people who don't want to wear condoms.
And it's just interesting, we're talking about like the MSM community and the African-American community here. I worked for a few years in Miami with mostly Latino and Asian queer kids. And one of the things we try to do is really have these conversations, because I think a lot of times it's the purple elephant that nobody wants to talk about. And if we talk about it, at least it opens up a conversation to explore, well, what does that mean for you? Why fluids? What is that about? And who knows where that could lead.
And that also sort of emphasizes that sometimes when you start when a conversation starts not from HIV, but from issues that are of interest and relevance and that people want to talk about, then maybe you sort of accidentally do some HIV-related work, but you're doing it in a way that people can engage with.
Please.
So I was really struck by your comment that the Sun had only done like one story on MSM and HIV in Baltimore, and I was just wondering if you guys could talk a little bit about engaging media and maybe targeting media so that like some of this information gets to people who might be interested in knowing more about it.
What I can say is that, a lot of this is before my time on this project, but the project that I've described to you had, very much before my time, helped to, inform a lot of things that we didn't have data for, and the people who were involved in the project at both of the sort of first round and then the second round, each time sort of went out of their way to have press releases and to arrange schedules when things went out, because expecting this avalanche of phone calls from media and press, and just got nothing. And so there've been some deliberate attempts to engage, and in some of the alternate media, some of the local gay media have LGBT media have done some reports, but not a lot. And it, there's sort of mixed thoughts about what's going on, but it hasn't hit at, there's the sort of media moment, and then there's the media related topic, and those two things haven't hit well in Baltimore. And, you can talk about the local media capacity and, the sort of, do we even have a local newspaper is a relevant question. And There's a lot of limitations, I think, to it, but it's, I mean, the bottom line is that there just has not been a lot of media coverage.
I guess I would add that, when you think about media and communication mobilization, there obviously there's a lot of different audiences, and a lot of mainstream media is obviously for a mainstream audience. The other reality is that HIV in many ways fell off the agenda of the gay and LGBT movement and community for a number of years, and the focus, and maybe rightly or wrongly, has been on a whole set of other issues: marriage equality, gays in the military, repealing Don't Ask, Don't Tell, a whole array of other issues. I think one of the things that's really striking is that there seems to be something of a cohort effect that's happening where we're seeing a return and a new awareness of some of the older forms of activism. So, for example, Larry Kramer's play A Normal Heart has had huge runs of success in a number of cities, starting with the New York revival, but also in Washington. There are several documentaries out right now that are also really galvanizing young folks around this. How to Survive a Plague, which is a history of ACT UP. We Were Here, which is a history of the epidemic in San Francisco. And this was sort of brought home by the protest that happened a couple of days ago. Do people know about the ACT UP protest in John Boehner's office? Yeah, well, here you go. All right, everybody's over 18 in the audience. Yeah, John Boehner, don't be a dick. Budget cuts make us sick, right? But everybody chanting that in the speaker's office was naked, right? They all took off all their clothes, and they had all these great signs and symbols on their body, and it felt like very much a revival of the old school, in-your-face AIDS activism. And I just happened yesterday to be, I gave a lecture for World AIDS Day at Yale University, and Greg Gonsalves, who was one of the leaders in that movement, is there as a student now. And we were talking about this, and he said, yeah, it's ACT UP, it's back, it's a cohort effect, it's generational. And I think that's incredibly important, whatever happens in the mainstream media, because this is also a conversation that young gay men, MSM, have to have with each other. And have to you see these numbers, we're talking about half the population in some of these sub-epidemics. This is not a side issue, right? It is an enormously front and center issue. Did you have a question sitting in front of her? Ah, okay.
Can I ask another question?
Sure.
What are the efforts in Baltimore to recruit more gay African-American physicians that our youth can feel comfortable going to?
I'm not sure that I can answer that specifically, but I can say that that the two, to my knowledge, the two clinics that do a lot of work with adolescents, particularly around HIV, both of them are very attuned to the epidemic among particularly young Black gay men, and have some really fantastic work happening within those clinics, and both actually have some sort of nice diverse representation among their team. So that's actually I think a good thing that we can say about what's happening in the city. I mean, certainly you can say a lot more about what we can do in other service provision, but in terms of that part, I think there's some nice work happening.
So why don't we close there, I think. I want to thank our three panelists and for these tremendous talks. And we'll take just about a 5-minute stretch your legs break and then go into the CFAR Awards ceremony, because I see people, a couple of our CFAR leaders and faculty members starting to come in. So thanks to all three of you.